Hello and welcome to the Health Foundation webinar on how successful change happens in the NHS. I'm really delighted to be here with you today and delighted my colleagues are able to join us and really looking forward to having a good debate and discussion. My name is Clare Allcock. I'm a Senior Policy Fellow at the Health Foundation, currently on secondment from the Department of Health. I'd like to introduce my colleague Felicity Dormon, who's also a Senior Policy Fellow at the Health Foundation, and alongside myself is a co-author of the report that we're going to be talking to you about today. I'm also really pleased that Dr. Julie Reid has been able to join us. Julie is Academic Co-Director at the National Institute for Healthcare Research, Clark, in North West London. In case you don't know what a Clark is, it's the Collaboration for Leadership in Applied Health Research and Care. Julie's also a Health Foundation Improvement Science Fellow, so has got a real wealth of experience to draw on, which will be great for today. So this webinar is really an opportunity for us to talk to you about our report that we've published recently called Constructive Comfort, Accelerating Change in the NHS. So Felicity is going to be giving an overview of the report and its findings, and then Julie's going to be talking a bit more about the reality of change and how it feels working on the front line. And then afterwards, we're going to be picking up on your questions. So please do submit questions as they come to mind throughout the presentations or in the discussion and questions afterwards. We'd be really interested to hear your thoughts and reflections. So you can type them into the box on the left-hand side of your screen and send them through to me. I'm going to be monitoring the questions as they come in on the iPad. So if I'm looking down, that's what I'm doing. I'm not just checking my emails or Googling. Yeah, we'll move on to the questions once Felicity and Julie have finished their presentations. So do you want to kick off, Felicity, with your thoughts?
Absolutely. So, successful change in the NHS, what national bodies can do to help. Firstly, why are we interested in this subject? Well, the NHS has a lot of changing to do, a big financial gap and also transforming to new models of care. And interestingly today, the Nuffield Trust published a survey of senior leaders in the NHS saying that 3 out of 4 of them didn't have confidence that the NHS was going to make the savings that was needed by the 5-year forward view. So, a challenging picture for change. I'm going to be mostly talking about findings from our report, Constructive Comfort, which looked at changing the NHS. We also published 2 documents alongside. Firstly, an evidence scan of the barriers to change, and also some specific work looking at hospital transformation. So what did we find? So firstly, successful change looks like this. We have 7 factors for successful change. And these are what make change more likely. So leadership, both leadership in senior leaders, but also right down through organisations, so all the people doing change and leading their colleagues. Secondly, a culture that's supportive of change. So culture is sort of the way we do things around here, and much easier if that is supportive of making changes and new ways of working. Data and analytics, huge thing, really important to both know how you're doing in the first place, but also how performance changes as you're trying to do your improvement intervention. Also management practices, and again here it's really important to manage your change programme well, so project management and all of that, but also to have and to be in an organisational context that has good management, so basics like accountability and processes are effective and in place. And speaking of sort of your organisational environment, we also found that environment makes a big difference. So then that's anything outside your standard unit of change. So if you're a clinical team, your environment is your senior leadership, the hospital maybe you're working in. If you're a provider, it's your commissioner. Maybe if you're a local health economy, then it's the national bodies. And as I say, then going with the grain of the change you're trying to do makes a huge difference. Resources and support for change. Difficult given the financial challenge, but most of the organisations that do change well have dedicated transformation teams or have people with really set aside parts of their job to do change. And then support is also moral support, so it's also having senior executives who are on board with the change, or a supportive commissioner, or a national organisation who's really helping you to get to where you need to be. And then finally, capabilities and skills. And this is both hard skills like, say, improvement skills or project management, but also soft skills like communication, negotiation, leadership. Well, we've spoken about leadership, but leadership skills. And I think that's really nicely illustrated here by an acute trust chief executive that we spoke to, saying it's one thing to get the tangibles right, but actually the relationships is a harder thing, and that really separates out the sort of the calibre of leaders. So if that's what successful change looks like, why doesn't it happen? And we spoke to a lot of people who encountered different types of barriers in terms of change and transformation, but we found that we could gather them under these 4 headings. And so these are the things that influence people's behaviour around change and can mean it doesn't happen. Firstly, recognition of change. So understanding there's a problem might be because there's not data, might be because problems are so entrenched that people don't really believe that change can happen. Secondly, capabilities and skills, fairly obviously, but important both for people to have the skills, but there to be enough people with those skills to really drive the change you're looking for. Thirdly, motivation, and what we found here was that it's really it's about people feeling valued, and also people valuing improvement and valuing action to improve the system. And then finally, headspace. This came up in every single conversation we had on change. People locally feeling like they just had none. So too many competing priorities, too much to do, and their business as usual taking up in the entirety of their time with no space left to think about locally driven improvement and changes to services. And again, I think this is illustrated quite nicely here. When we spoke to commissioners, they spoke to us about the Monday morning Whitehall delivery meeting and the effect that had on their priorities and their ability to drive forward other change that wasn't focused around delivery, which is was quite stark, I think, as someone who worked nationally. So what can national bodies do to support change? What are their different options? We came up with this typology of 3 different types of action to support change. So prodding organisations, proactive support to organisations, and also people-focused policy. Prodding organisations, we mean sort of traditional policy levers, so payment systems, targets, competition, performance management, that kind of thing. When we talk about proactive support, again, support for organisations, so the kind of work that intensive support teams do nationally, but also moral support. I talked earlier about the difference that made, and when we spoke to people in the Pioneer programme, just having sort of permission, national permission and national support for the kind of changes they were making seemed to be a big part of the benefit that people felt from being on that programme. And then finally, people-focused policy. So not only the sort of the hard things that the national bodies can set about people's professional lives, like pay, like conditions, professional regulation, but also the softer side, so professional leadership, what it means to be a clinician or a member of a profession working in the NHS, and also national behaviour, I think we found really sets the tone for local interaction, so it has an impact on the culture of the NHS. And I think this was really illustrated in these, and when we spoke to local areas, they spoke a lot about how central behaviour impacts. So for instance, planning, a lot of central focus on planning, but sometimes with unrealistic expectations, which people spoke to us as being quite disempowering, and also not that much focus or not that much perceived focus on execution. So a feeling that planning is important for central bodies, but they don't necessarily care about the results. And I mean, that's obviously not the case, but I think that's how the focus on planning comes across. So how can national bodies support change better? We made 4 sets of recommendations around these areas. Firstly, a single theory of change. And so by this we mean that all of the national bodies involved in policy, so not just DH and the statutory bodies, but also people like professional regulators and the colleges, have a common view of, firstly, the change that we're driving towards, which I think the 5-year forward view produces really well, but secondly, how we're going to get there and how their actions are going to influence the NHS in order to see the change that they want. A single model of change, easier said than done, I think. Secondly, thinking about thinking about putting organisations a better blend of organisational levers. So thinking about a broader definition of success. So rather than just looking at performance today, looking at and you might say, taking the example of the 4-hour A&E standard, instead of just looking at that, patient experience, staff experience, the outcomes, also what's going on in the local health economy, and the health economy's capability to change and what they're doing there. So taking a much more rounded view of success to try and avoid the narrow focus which has unintended consequences and feels difficult locally, and then aligning performance frameworks around this, so that everyone at a national level is asking for the same things, and that's a nice clear message to local areas. Thirdly, on support, we recommend an NHS improvement strategy. So aligning what's there already in the improvement space, but also having a serious conversation and a serious think about what is the support that the NHS needs to make the changes that are being asked of it, and that includes support for commissioners. It maybe includes a regional convening function, and probably much more focus on this from national bodies. And then finally, thinking about people-focused policy. I think firstly, we thought an important thing was to assess the cumulative impact of national policy on people working in the front line. So to understand from their perspective what the various different national organisations, what their asks, what their demands were of people working on the front line, and how they coordinate, how they don't coordinate, and then use that understanding to align things better, and then also to use the national levers that act on individuals much more strongly to drive the kind of change that the system is trying to do, rather than it being a slightly different conversation to the targets or tariff or whatever it is. So that was a whistle-stop tour of our report. I hope you found it interesting. Here are mine and Claire's contact details. We're really looking forward to some discussion later, but we'll be really happy to carry on the conversation after this.
Thank you. Thanks, Felicity. That was great. It looks like we've got some really great questions coming through, but if anyone else has, really encourage other people, if you think of something that you'd like to ask from that or during Julie's presentation, do put them in the left-hand box of the screen. So, Julie, on to you.
Okay, thank you very much, and well done for tackling such a difficult area in healthcare. I think it's a really big challenge. Just before I start, I just wanted to reflect on my experience in the reality of change, which is what I'm going to be talking about. I've had the privilege of being involved in leading a quality improvement research programme, Clark for North West London, for the last 6 years, which has given me real first-hand experience of what it's like to be doing change on the front line. But also through the Clark programme and my Health Foundation Improvement Science Fellowship, I've been conducting empirical research into the reality of change as well. There we go, that's my contact details if you would like to contact me as well. So to start, I just wanted to kind of draw a picture of kind of what I'm going to be focusing on today, which is around the reality of doing change. And so the quote at the top, many of you may be familiar with from Theory of Constraints: all improvement requires a change, but not all change results in an improvement. And the guy I have underneath pushing the boulder up the hill is really emphasising the hard work that's required to make that transition from being very busy and putting a lot of effort in to actually being successful in achieving the improvements that you want. the three areas that I'm going to focus on in my talk today. Firstly, understanding the impact of policy levers, and I think that will pick up on a lot of the areas that the report touched on. Secondly, understanding the process of change and sharing some of our experiences of the reality of doing change on the front line. And thirdly, reflecting on the current landscape that Felicity reflected on, being very busy, quite crowded, and how that really feels for people on the front line. So before I start, I just want to share this quote. It's a terrible feeling thinking that you could have done something differently. This quote comes from a nurse who's been working on the front line and experienced a critical safety patient incident where a patient died. And in her view, this could have been avoided if proper care had been given in a timely fashion. For me, this quote is really powerful in emphasising the very strong relationship between patient outcomes and staff well-being. And in my view, there's a huge amount of intrinsic motivation in the NHS for people to do their jobs well. And this quote, I think, demonstrates the enormous personal impact that can have to staff when you're working in a system that prevents you from doing your job well on a regular basis. So starting with the high level of thinking about policy levers, I think this is quite a contested area and quite a complex area to understand. And so I just wanted to share two examples of policy levers that we've been involved in working with and considering the different types of impact they've had on care. So firstly, a project that we're involved in evaluating in Clark, North West London, looked at the introduction of an alcohol-related QOF, a quality outcome framework, that essentially provides GP payments to incentivise good payment, care in practice. And in this instant, this was around performing an alcohol screen during a GP visit. So this QOF was immensely successful. It resulted in over 10,000 patients being screened for alcohol dependency during the time of the QOF initiative. However, when we did some further research, we found that of this kind of huge population that had been screened, only 7 patients had actually been referred for onward alcohol dependency support. So clearly the target had been successful in motivating people to complete the task that it was asked to do, but it hadn't really incentivised the system to drive more significant improvements in healthcare and consider the full patient journey that needed to be looked at. Another target that we've been involved with, or I've been involved with quite closely, is the 4-hour emergency care target, which Felicity mentioned. And my first introduction to this target exposed me to two very different worldviews about the 4-hour emergency care performance management target. Firstly, I experienced with frontline teams where I would meet them and they would be very frustrated by this target, which they saw as very bureaucratic, led by management as a performance management target that bore very little relevance to their day-to-day clinical working. And I even heard people accusing the 4-hour target of resulting in the death of patients that they were looking after. On the other hand, I was very privileged to work with a number of the leading clinicians in the country who worked on this target and was very impressed by the depth of knowledge that they had about this measure, how they saw it acting as a measure for the whole system flow, identifying issues of quality and safety in the system and being able to identify areas for further improvement. So I became very curious as to the difference between these two worldviews and how can they both make sense around the same target. And over the last 4 years, I've been deeply involved with both local work with healthcare organisations across the UK, but also with governments in the UK and internationally, looking at the introduction of the 4-hour emergency target. So to start off with, I'd like to reflect about, well, what is this target trying to achieve? And I think different views on this is one of the kind of core reasons as to perhaps how people see the target and interpret it into their daily working. So to start off with, many people associate the 4-hour performance standard to do with the timeliness and efficiency of care. So that seems fairly obvious. What people don't often realise is that the 4-hour emergency standard actually came from a patient-led movement. Patients were frustrated with the length of time they had to wait in an emergency department. And as a reminder, in 2002, it wasn't uncommon for people to be waiting over 12 hours to be seen in an emergency department, so very long wait times. So this came from very... No, really don't. Okay.
Healthcare in action.
So it came from a very much patient-centred target. And as this target's been in place now for a long time, the evidence and the research that's emerged around this target has demonstrated that the speed with which patients transfer through the emergency department and get sent to the right place of care with the right expertise to look after them is closely correlated with patient outcomes, including mortality and morbidity, and also reduced length of stay of patients in hospital. What people don't often realise is that this target is also closely associated with equity of care. The people who often end up waiting longest are the most vulnerable. Frail patients over the age of 85, people with mental health issues, or people from black and minority ethnic groups. So actually by introducing a universal performance standard, you provide a fairer system for all of the people being served by that service. So that's the target in theory. Why is it so different in practice? Our work has shown that frequently when people think about the emergency care target, they think it's the job of the emergency department to get this right. So they put more and more pressure on the emergency department to push patients through and to increase the pace at which they see people. Focusing on the target on this way can make it seem quite an impossible task and quite difficult to achieve, and can create a lot of stress for the staff in those environments. And we see some quite negative consequences of this type of behaviour. So just as one example, by trying to kind of move patients through quickly as possible, people just put them in whatever bed they can find available elsewhere in the hospital. This could result, for example, of a respiratory patient ending up in a gynecology ward. The implication of this means that they aren't with the right clinical team, with the right clinical expertise. They may not have the right equipment next to them to look after them. And the clinical team who are responsible for them may have to travel around the hospital looking for the patients that they should be caring for, so introducing a lot of inefficiencies. This is known as boarding. And boarding has been demonstrated to be associated again with poorer patient outcomes, so increased mortality, morbidity, and it can increase the length of stay by up to 1 or 2 days. So actually by quickly moving people through the emergency department and into whatever bed's available, you're actually making the long-term problem more complicated. There are less beds available, so it's harder to find beds to place people from the emergency department as they come into the hospital. The graphs on this screen show boarding from 2 of the hospital organisations that we've worked with. And so the size of the bubble represents the number of patients that were boarded in each of the clinical settings and from which discipline they came from. And as you can see in the bottom chart, over 33% of patients in one particular hospital we looked at were in the wrong setting, under the wrong clinical area for their care. So how do we think differently about this concept of flow? So firstly, as I hope you can tell from the narrative I've been talking through, that actually the flow through the emergency department is dependent on all other parts of the healthcare system, most notably through the downstream wards and where the patient goes when they come into the hospital, but it's also closely related to work of the ambulance services and how people arrive at the hospital and what happens after people leave, so the community services. And so the 4AD performance standard actually acts as a very effective pulse of the whole system, giving you an idea of how it's working as the whole system rather than the emergency department on its own. So then zooming in even further, I want to talk about introducing change into these systems. So if we recognise that all of these systems are interdependent, how can we start thinking about making improvements not just in the emergency department, but for example, in the downstream ward? And so the schematic in front of you, I've drawn from some of my research looking at people trying to make changes in relation to emergency flow and just trying to show the number of interconnected areas that they've had to deal with to introduce a single change. And as you can see, some of them may be related to the wards, some are dependent on support services or other infrastructure such as data and patient notes, and some are actually very much out of control of the people in the wards. They're dependent on organisational decisions or external factors. So you can start to see that this process of change is actually very complex, and all of these things are interdependent and need to be negotiated and navigated through the process of change. So in approaching such situations, we would certainly agree with some of the recommendations from the Health Foundation that measurement is incredibly important, and feedback from the people involved. So you're understanding how well is the change working, and unfortunately, because of this complexity, it's very hard to predict in advance exactly what will work and what changes you're going to need to make or what barriers you might need to navigate. So it's very important to use the measurement to assess what's really happening, not what you might hope is happening, and to use as pragmatically think how quickly can we learn about what we need to do, and use an iterative approach to development so that you're building on the learning and overcoming different obstacles and challenges as you meet them. And then zooming in even further, within each of the cogs that was represented there are many, many individual people and professionals and patients who are part of the systems that we're talking about. And whenever we're talking about change, it's really important to remember that we're asking people to make these changes, to change their routines and their behaviours and their practices. Often this can result in resistance, but genuinely there are good reasons for resistance that need to be understood and discussed. So for example, in the previous study that I looked at, some of the consultants involved were very resistant to changing their ward round practices from 2 days a week to 3 days a week. And the reason for this was that they had outpatient clinics, they had other commitments as for research or management responsibilities that they had. And so actually this need to be understood and it need to be negotiated, and the change that they wanted to make in the ward had spill-on effects that impacted the rest of the hospital that need to be understood. So I guess our view is very much that patients and staff have very valuable perspectives about the changes that are being introduced, and actually engaging them, they can be very powerful problem solvers to help overcome the challenges that people face. So moving on to think about the role of policy that I think is currently having in the landscape, I just wanted to share this quote from some of the research that we've been doing. So I think the frustration in it all is around that they've got double the paperwork to what they had 3 years ago by all these initiatives. The nursing staff are already on their knees, stretched to the limit, being told to do this, that and the other with no extra resource. You can't just expect people to absorb it into an already overloaded work plan. And to me, this represents some of the issues that have been highlighted with the report around the complexity of the landscape that people are working on, but also there's this idea that is often talked about called the barnacle theory, where you have a problem, so people stick something on the side to make it work better, and it may act as a temporary solution, but people keep on adding more and more fixes to the problem that they're trying to solve. And they can make it very unwieldy, a lot less nimble than it was before, and create a lot of drag in terms of how efficiently the staff can work. And what we very rarely do in healthcare is actually look at the changes we've made and think about how we can kind of simplify and streamline all of the different quality initiatives that we want people to take on. And this can lead to change fatigue. So whilst I believe there's a huge amount of intrinsic motivation in the NHS to do a good job and to provide good patient care, people constantly being involved in more and more improvement initiatives that aren't coordinated and aren't joined up can be very tiring, and especially when they don't always lead to successful results. One of the consequences of this, which I've identified in my research, I've termed improvement collisions. And I think this is a really important area for policymakers in particular to think about. Generally, our experience is that policy doesn't really join up the different initiatives that are being run, and there are many different policy organisations active in quite similar or overlapping spaces. So the top left diagram of the two cars colliding demonstrates that from work we've done, we've seen two different improvement initiatives championed by different organisations, policymakers, taken on by different people within the organisation who are working really hard, but actually in the same area. People put a huge amount of emotional and effort in. As was already explained, people are often doing this on top of their day job, and so they're doing this at the weekends, in the evenings, And so when things, they start scaling up and they realise that there's this kind of clash of improvement approaches, it can result in very personal conflict between different people involved, and has a very strong emotional toll on the people who are working in this area. The top right with the overall kind of collision, I think I've already highlighted with just the sheer volume of improvement initiatives that people can be asked to be involved with, and that we often see people doing many, many improvement initiatives and being incredibly busy, but not necessarily making a real impact in any of the areas they're being asked to look at. And finally, on this slide, I think the most distressing that I've seen, I've called the tidal wave, which is where we've observed people, for example, working in emergency care and for 3 years, really targeting most at-risk patients, making sure they're getting treatments as soon as possible. And through an organisation initiative with no consultation and no engagement of the unit, a new urgent care centre was set up that totally wiped out all of their improvement work. And the emotional investment that people have put in this is huge, and it can actually be very soul-destroying for people to see all of their work wiped out quite carelessly without much thought for the implications that it may have. So moving forward, there are 4 areas that I think we really need to focus on, that I think link with the recommendations from the Health Foundation report. One is improvement expertise, recognising this is actually an incredibly complex area, and we have a huge team of academics and expert clinicians working on this, and it's really hard to solve the problems that we're facing. So increasing the expertise that we have for improvement. Building improvement capacity. We know that the kind of concepts that are related to improvement are very new to many people in healthcare. So just to give a brief example, we found that when we've approached people around emergency care flow, people are often really frustrated at not being able to do their job well. But no one sees their job as looking after the system and supporting the flow of the system. We train people as individuals, not to work together collectively. So I think there are some really systemic changes about how we educate people and how we support people to think about improvement. Improvement infrastructure, whether that's data, training, other support, and importantly sharing knowledge between projects so that we're building on successful work and helping people prevent making the same mistakes over and over again. So finally, I would like to really, make a plea for both policymakers and academics to move away from just thinking about preparing and planning for improvement or maybe evaluating how it's gone, to really understand how change is conducted, and thinking about using formative evaluation, ongoing feedback to really drive the success of changes we're trying to achieve. And finally, to end on a positive note, this is just a quote from one of the people that I interviewed who has been using a series of quality improvement tools and methods to help understand his emergency department. And as you can see, he's kind of made a shift from feeling that he was a bad person for not being able to make his department work and not understanding why that was, through to using a kind of more scientific and structured approach to change that has enabled him to solve the problems that he's facing.
Great, thank you. That was really interesting. It was great to get your perspective on that. So we've got some really great questions that have come through, so we'll move on now. But if anyone has any further questions that they think of while we're discussing, do send them through to us. So I guess one of the first things that's come through has been about why this report? Why did we decide to kind of focus on that? I don't know whether you want to kick off and I can.
Yeah, sure. So I think Health Foundation has quite a history of looking at and supporting improvement in organisations. So we've done a lot of work with clinical teams, things like the fellowship that Julie went on. And I think that's really shown 2 things. So firstly, change is difficult, but secondly, the national environment, so national policymakers have a huge impact on the success of even quite sort of clinical team style changes. And so I think it was from a realisation really at the foundation that if we wanted to see the kind of change and improvement in quality as services that everyone wants really, it's also about the national levers and the national approach to supporting change. So
And I think there's a real recognition the 5-year forward view has been really great at kind of describing what new models should look like and how we should be taking things forward, focusing on kind of what are those things, but probably much less focus on how are we actually going to do that. So I think that's what we were keen to kind of think about in that respect. So we've also had a question about asking who we spoke to when we carried this work out.
Okay, so we spoke to, I suppose, a mix of people. So frontline clinicians using our links to the Health Foundation, to people involved in improvement, involved in changes. And we also spoke to people at national bodies, so system leaders, academics as well, who are active in this field. And particularly as well, our transformation in NHS providers spoke to a set of chief executives and senior board members, style people at acute providers and some community providers too. Great.
So one of the questions, it's a great question actually, has come through, which I don't know whether you want to kick off, which is saying that talking about the people-focused element of our report, that it needs to be more than just staff, it needs to be about people who are involved in services or who are patients themselves. And I know you kind of picked up on that in your presentation, but do you want to kind of say a bit more about that?
Yeah, no, I absolutely agree that involving patients is really important, and it's big. It's focus of our work around quality improvement. I think they can provide unique insights into the system, because they're often the only people who see all the different bits rather than the bit that they're responsible for. So I think that's really powerful. But also some of our work, research we've done has shown they can be really powerful change agents as well. So often when you involve patients in talking to staff, it can become very real and create a real motivation for change. But also they can help unblock obstacles. So we've found, for example, that in healthcare, people might be, oh, well, we don't really know social care, and we don't really know, we've got a problem, but we're not sure how to approach it. And the patients will just be, well, I'll go and speak to them. I know so-and-so there. So they often have much broader networks than the people working in the organisations. So I absolutely agree, patient involvement is key and can be a real catalyst for change.
Great. Yeah, absolutely. I mean, clearly it's the right thing to do, but again, we've also, in our conversations, the role of it as sparking people's intrinsic motivation and really being able to make the case for change much more strongly when patients and people using services are involved. I think the positive energy when you talk to projects who have done that is amazing.
And particularly, the sort of large scale change that is realistically going to be required is, if we don't involve patients, then it's not going to happen, is it? I think it's.
I think from our work, I guess building capacity within healthcare organisations for people to involve patients. I think people often find it quite overwhelming if they haven't done it before. It can be quite anxious about it. So thinking, how do we support staff to do it, and what methods are the best to use in what circumstances? So I think it's another area in terms of building capacity that's really important as well.
Which is a great segue to our next question. It's like I teed you up for that, which was somebody asking about how we improve capability and capacity within organisations. And I think there's probably a perception that sometimes that sort of capability can be brought in, and whether it's from management consultants or from some of the national bodies that help support improvement, which is great, but it doesn't necessarily skill up the teams to do it themselves. I don't know what your kind of perspective on that is.
Yeah, no, I think it's a really interesting question, and I think it's really important that staff have an awareness of improvement, and certainly some of the key elements around, for example, understanding how they all work together in teams, the processes, the systems that they work in, understanding the basic concepts of change and using data for feedback and stuff like that. So I think building that capacity across the NHS is really important, but I also think that there are roles for expertise in quality improvement, that not every member of staff needs to be an expert in data analysis or a great facilitator of conversations between different groups. So I think thinking how we can most cost effectively deploy these resources in organisations is really important. And as another view is, I think often people, when you bring in different external people, over and over again, they'll each bring their own change approach. And we often see organisations with maybe 5, 6 different change approaches going on. And so for the staff, it just becomes management speak. They don't relate it to how they work. It's not their approach. It's just like another hurdle to kind of engaging people in improvement. So I think building that organisational language of improvement, a single organisational approach, and that may be slightly different in different organisations. And I think that's okay, because they may have different needs, different requirements. But having something that they really feel ownership of, that every staff member has an understanding of, I think is really important.
I think that's certainly something for me that came out really strongly when we were talking to people is almost, pick a methodology. Almost it doesn't matter what the methodology is, but stick with that for your whole organisation, so it becomes kind of the language that everyone uses.
Yeah, absolutely.
Yeah, I mean, I completely agree. And I mean, I think in the long term, it's about education and training and making skills to support improving services part of just standard training for everyone going into the NHS.
Yeah.
So.
And I think something I would add to that is I think often people perhaps assume that what they bring in off the shelf is going to work for them locally, and then often may be frustrated when it doesn't work. And I think I would definitely advocate as having some level of local evaluation and feedback, so that you can change methods or change how you teach them or change how you facilitate them to make sure that they really work for you and your organisation, that it's not just a tick box exercise or something that doesn't make sense to your staff. So I think building in that kind of organisational learning mechanism is really important as well.
Great. So somebody's asked a question about the fact that quality improvement initiatives take up an awful lot of time and staff resource, which can put even more pressure, I guess, from the headspace point, more pressure on people who are already overstretched, and asked whether we've got any advice. I don't know, Julie, if you want to...
So I guess my main advice, and I know it's really hard to give in the context that we work in because it's very crowded, but I think it's being realistic. Improvement is hard. If you want to do it well, you're going to make it better for patients, you'll make it easier for staff to do their job well, rather than just putting more pressure on them to kind of work harder in really difficult situations. So I think people do need to accept that, to do improvement well is complex. And I would advocate that it's much better to focus on a small number of really important organisational priorities than have everyone, 100 improvement initiatives that no one's got the time to do, no one's got the energy to, maybe competing, conflicting. And so I think really thinking carefully as an organisation about, do you even know what's going on in your organisation? Do you know the number, the breadth, what topics they're on, and how many of them are really hitting what's important to you and your kind of overall performance as an organisation?
So it comes back to prioritisation, doesn't it? So yes, it's absolutely hard. So you need to do stuff that's going to make the biggest effect. Yeah. And I think also support. So because it does take time, you can't expect to do it on top of everything else and that just magically happen.
I think some of the feedback we had from those organisations that seemed to do this successfully is where they had strong leaders who were kind of almost acted as a buffer to kind of letting their teams get on with things and maybe kind of fighting the fight upwards, which is obviously a very challenging thing to do and is not something that everyone has the leadership skills to do. And I guess it's again part of the sort of building capability at all levels of the system.
Yeah, and I think it's been very interesting to see how the 4-hour emergency target has been interpreted by different leaders, and some who have this really in-depth understanding of what it means and that it's a quality target, and other people who, and maybe they do have the insight, but it's not being translated or communicated to people on the front line, and so it becomes much more of a you just have to meet the target rather than, well, let's really think about how our system's working and think more carefully about where we can invest our energy.
So another one of the questions that's come through, which is, I guess, in terms of probably someone from a policy perspective, is saying, what can I as a working level policymaker do differently to make change more likely? I don't know, Felicity, if you've got any thoughts on that.
Easy question, Claire. So, I mean, I think it's difficult because policymakers are under the same pressure that people in the NHS are under. There's a lot of pressure often for ministers to have results really quickly and to find easy ways of getting things done. And we know that that just doesn't work. So lot of what policymakers are pressured to do then puts further pressure on the system, which then ends us up where we are with all these conflicting priorities. And so I think it will need leadership from policymakers, particularly senior policymakers. But still, as a working level policymaker, I think there is a lot you can do in terms of understanding in the area that you're working in how people feel, the kind of pressures that they're under, and then communicating that upwards to your seniors and the minister, and also thinking about support and thinking about putting support into everything that is doing. So if there is a sort of a real prod to do X, trying to match that with a supportive offer, and then also think about, okay, from the people's perspective, what's happening here, how can we make that better?
I would agree. It's the kind of balance of all of those things together.
And
Have you got it?
No. I was going to say, you can even, if you can't fix it, you can probably take small steps and just increase.
And I think, so I'm not sure how easy this is to do in practice, but I think what I would love to see in the future is policymakers having the humility to recognise that they will not have the perfect answer, and that we can never fully predict in advance what is going to work, and it may vary within organisations, and we may not truly understand the problems we're trying to solve until we actually get out and start trying to change the systems. So for me, I think the biggest thing that policymakers can do is build in that learning system, the learning organisation, the reflective practice, measurement for improvement, getting feedback and allowing things to change. If we learn that it's not working, or we learn that there are other problem areas that we hadn't anticipated, so that this can be built in over time and kind of having an iterative development of what works, rather than planning in a room and then hoping that it's going to work.
Yeah, I'm going to be going back to the Department of Health at some point, so I will certainly try and take this back with me and spread the word. So we've had another question about asking, did you find evidence of too much focus on making change happen rather than focusing on what the change is trying to achieve?
So that's interesting. So it didn't come up loads, but Julie's point that she was making about lots of effort to make change and lots of effort to make change happen, but without necessarily a clear alignment between them, or without thinking about the community. So it's almost what happens at a national level, but on a local scale. So nationally, there's lots of change that wants to be happen. There's lots of different things, but they're not really coordinated. And the same might happen and does happen in some, say, hospitals. So I mean, I think that certainly, I suppose, lucky the changes that we spoke to people about were generally motivated by wanting to do better for patients and wanting to do better for people.
I think there can be a pressure. I mean, certainly for having worked in national organisations, there's a pressure to just do something and show quick wins, particularly. You know, there's always this quite, how are we going to show in the first 3 months to ministers that we've done something? And it can kind of skew the effort. So I think there is certainly, that's definitely a real danger that you kind of, it's almost like what you were saying, you kind of hit the target but miss the point.
Or something that did come up in our work as well was rushing to the solution. So knowing that there was a problem, and then instead of sort of taking the time to work out exactly how to change it and sort of what needs to be changed, just sort of jumping to the solution. And I think that can contribute to the feeling of change fatigue, and that it's less likely to work. So then people have experience of trying to do stuff and it not working, and it's all quite disheartening.
And I think there's some really interesting research looking at the role of different performance measures and how they can distort people's behaviour. And again, I think everyone's trying to do a good job, but there are instances of where people know, we need 100% of this form to be ticked. They will fill the form incorrectly regardless of kind of what's happening in patient care. And often that's, they may be really busy on the ward trying to do the best thing for everyone, and they'll be like, I'm fairly confident I would have got everyone in the time I was meant to, so I'll fill in all the sheets at the end of my shift, and we're 100% again. So I always say, if ever anyone's saying they're 100% or 0%, always be very suspicious about where that data's coming from.
So someone's asked a specific question about the concept of improvement zones, and to say a bit more about that and how it might work.
Okay, well, so
if you want to kick off.
Yeah, sure, and then let's have a discussion. So this is an idea we came up with, again, thinking about the fact that change is difficult, and especially change, say, at a local health economy level, and the changes needed by the 5-year forward view are really significant and will take an awful lot of effort and an awful lot of headspace. And the idea that, especially in the financial situation that we are, doing everything that's business as usual while that change just doesn't really feel very practical. So we came up with the idea that zones who were going to go through a big change could have sort of improvement zone status, which would mean they have a discussion with national bodies, and this is all the different organisations working locally to agree what performance is going to be over, say, a 2-year period, and adapt those expectations. So not only performance expectations, which might be a bit relaxed, but also expectations around change and what the change is going to be and how that's going to be driven. And so just to give people some of the time and the headspace to really improve services rather than continuing on the treadmill, which doesn't really make anything better. I think that was our idea.
And it does seem to be growing kind of traction. So I know a colleague of ours went to King's Fund conference yesterday, which was looking at the first 100 days of a new government and what they might do. And Sam Everington, who's one of the GP leaders who's working on the new models of care programme in NHS England, was talking about the idea of a target holiday and for improvement activity, and it seems to be kind of growing traction, which is great. Yeah.
And I've certainly seen some of the research that I've done in the States in some of their high-performing quality improvement organisations, that they're very sensitive to the context of the people they're working with. And so, for instance, people would be saying, well, they've just been through a restructure, or they're very short of nursing staff at the moment for X, Y, and Z. So, we've got this one initiative, but we're trying not to overload them at the moment. And so I guess making sure that people have capacity just to do the day job before you start kind of adding on loads of additional work. But I guess it's a constant battle. Yeah.
So, and probably one of the final questions is, what's the kind of reaction been to the report? What next? I don't know what you...
So shall I start on that? And so, I mean, I think... obviously, we think there's been a positive reaction. I suppose people haven't necessarily told us they hated it. But more seriously, we've sent this to a bunch of people working in national organisations and had some positive feedback, and we're hopefully going to be following that up with some workshops and more conversations with national policymakers. We're also going to be doing some thinking around some of the specific recommendations and what they might mean in practice, and we'll be publishing some blogs or some workshop write-ups and that kind of thing. And finally, I mean, this is a space that Health Foundation will be in the long term, so it links really well with all of our local work on change, and so we'll be continuing to think about what national bodies can do to try and support change better, how we can continually be improving the system to get us to sort of higher quality healthcare, which is what we're here for.
Yeah, I would echo that. I mean, we are, as Felicity said, kind of continuing discussions with national bodies around some of the specific recommendations, and going to talk to teams working in kind of some of the large organisations about how they do their work.
Oh, we're going to talk to Denmark.
Oh, we had a request from Denmark this morning to go and talk to them, so that's exciting.
Yeah. And I think from AS being a recipient of the report, I think for us it's really welcome to have people trying to draw attention to this at a policy level, because I think it has felt like a Cinderella area for a long time and hasn't received as much attention of a lot of the other types of work around either planning for policy or evaluating policies, whereas actually, well, how does it get done on the shop floor feels very left out. So I think we really welcome it, and if it could shift, for example, the investment in research funding, which currently I think a very small fraction is looking at implementation and the majority is looking at developing new evidence, which is of course really important, but we have so much evidence that people aren't benefiting from already. So how do we close that gap between what we know we should be doing and what's happening in practice?
That's the challenge.
Yeah. Well, great. Thanks so much to my colleagues, and thank you to you for joining us today. I think we've had a really interesting discussion, so it's been really good. So the documents we've been discussing today are all available on the Health Foundation website and via the link on this webinar, so please do have a look. And do check out any of the further resources we've got on the Health Foundation's website, and look out for future webinars, which I'm sure will be coming. There is a short survey that will be circulated at the end of the webinar, so if you could fill that in, that would be really great. Thank you.